today on Thursday, March 26th. We are so happy to have you join us. We're excited you're here. And I am very excited about our speaker today. Before we get there, we have put the today's agenda in the chat. And in the interest of time, we would like to ask everybody to please share your introductions with us in the chat. And I know it's been about a month since we've met. Our last meeting was February 26th, exactly a month ago. And we had a wonderful panel, and it was on addressing systemic racism and homelessness, especially as it pertains to Black or African American Angelenos experiencing homelessness. I have to say I'm very biased towards all of our panelists and our moderator that joined us this evening. So thank you so much. If you missed that meeting, it is available on our Empowerment Congress website and in Praxis. Praxis is my favorite periodical on homelessness, all things happening in homeless services, whether it is from a federal perspective, a state perspective, or a local perspective, local Angelino perspective, California state perspective, and our country at large. If you are not receiving Praxis and would like to, please enter your email address in the chat and we'll make sure to get you subscribed. Um, with that, I would like to turn it over to our Empowerment Congress founder, who also is really great at Zoom backgrounds. So, without any further ado, Supervisor, may I turn it over to you, please?
You may, Madam Chair. Thank you
Thank
very
you.
much for your steadfast and consistent leadership, committed to a subject that is not for the faint of heart. It is for those who believe in the fundamental dignity and worth of all people, irrespective of where they may find themselves at this point in their journey. And you've been stand up and unapologetic in that regard, and we are deeply grateful for you. And I speak on behalf of the co-chairs of EC, the Leadership Council of EC, and the body as a whole, because we know that this issue cannot be left unattended by those who are civically engaged and are committed to the well-being um, of our city and our county, um, for uh, the good of all involved. That is to say, to appeal to and draw on our better angels. So tonight we continue to educate ourselves and deepen our understanding by taking a closer look at the data pertaining to mortality and surrounding issues from a public health perspective. And to the extent that that is the case, I'm delighted to be here and let that stand as my preliminary remarks, Madam Chair. And Dr. Nichols, thank you for being here. We appreciate your presence. That would be the one and only Dr. Will Nicholas.
Woohoo! Thank you
Yeah.
so much, Supervisor. And again, Dr. Nicholas, it is such a pleasure to see you and a privilege to have you join us this evening. For those of you who do not know Dr. Nicholas yet, I would like to share a little bit of information about Dr. Nicholas. He is the director for the Center for Health Impact Evaluation at our Los Angeles County Department of Public Health and has been there for over a decade, if I'm not mistaken, right, Dr.
Yep.
Nicholas?
Yep.
Before joining DPH, Dr. Nicholas was at the UCLA Fielding School of Public Health. And before that has been doing amazing research throughout the community, particularly as it relates to policy, public health, family health as well. And Dr. Nicholas's work and impact continues to resonate through his tenure and service at Public Health, where he's been addressing the morbidity and mortality rates of our fellow Angelinos experiencing homelessness here in throughout Los Angeles County. So without any further ado, Dr. Nicholas, I would like to turn it over to you and say thank you so much for joining us.
Absolutely. I'm first going to share my screen and see if you can see what I hope you see, which is just a single sheet with a title slide. Is that what you're looking
Yes,
at?
sir. Yep, we see that.
Fantastic. And when
Thank you.
oh, wait, let's make sure that I can. There we go. Okay. Um, Excellent. Wait, one more second here. Okay. So, um, So this, yeah. This is I'm taking you through uh, a presentation of the results of our most recent, our seventh annual report on mortality among people experiencing homelessness in LA County. We started right before COVID. Our first report was released at the end of 2019, and so COVID took an early lead in the kind of focus of these reports, but there's been a fentanyl crisis in there too. So yeah, it's been a lot. But this year we actually is the first year. I'll spoil the punchline. This is the first year that we're reporting a decrease in the mortality rate in this population since in 10 years, in the 10 years of data that we have. So we are cautiously optimistic. Times are tough now. We're in a period of fiscal retrenchment, but some good news to share. So I wanted to start by letting you know that this year we've updated the format of our report to be more aligned with the collaborative action and action-oriented orientation um, of the prevention work that's informed by our data. So what we do is we start with an overall desired result or vision for our work, which is a safer, healthier Los Angeles County where people experiencing homelessness have dignity and access to the services and supports they need for health and well-being on their journeys towards housing stability. That is our overarching vision. And our data is now parsed into 6 key indicators. And those key indicators are what we are tracking over time because improvements on those key indicators will help us achieve this desired result. And then also our recommended prevention strategies are organized around these 6 key indicators. Another thing we've added this year is that for each recommendation now we have a list of implementation partners, whether they be county departments or community organizations, along with specific roles that each of those partners play in the implementation of that recommendation. So we're getting a little more specific and collaborative and action oriented. So I mean, this we've been doing it this way, but I think we're making the report reflect that orientation more this year. And I defer to our leaders, Dr. Muntu Davis and Barbara Ferreira. That was they sort of they were the ones who suggested that. So I want to give them credit. Um, so our first key indicator is you're not going to be surprised by these indicators. If you've seen the report before, I presented before, they are basic mortality indicators. The first key indicator is the all-cause mortality rate among people experiencing homelessness. Um, and so here, this is we have a slide like this for each of the other causes. So basically our 6 key indicators, we start with the all-cause mortality rate and then move through each of the 5 leading causes of death, and we look at the mortality rates for each of those causes of death, and then we have specific recommendations related to that specific indicator. So this is the big story. We released this, like I said, we released this report in early March, and it's nice to get some good news on the front page of the LA Times, which is what we got a few weeks back. So what you're seeing here in the pink line is the overall crude mortality rate, which had been going up slowly in the first 4 or 5 years, and then really increased sharply right at the beginning of the COVID pandemic. But that increase is mostly driven by the fentanyl crisis. And then we had a bit of a plateau for a couple of years. And then finally, after this plateau, we've seen a real significant, that's a 10% decrease from 326 per 100,000 to 2,994. Also, if you'll notice, the bars below tell you the exact numbers of deaths in the population. And we had 300 fewer deaths among people experiencing homelessness in 2024 than we did in 2023, which is a lot. And so it's a speaks to the hard work of all the departments and community organizations that have been working with us on this. But again, in our intro, and there's a letter in the front of it from Dr. Frere that just points out that these are the times that we don't want to take our eye off the prize, because we're moving in the right direction, but we still have a way to go to get back down to where we were prior to the pandemic. So yeah, so about a 10% overall decrease. And then what we also do for all of our causes of death, you may remember this from before, is we create these comparison graphs where we can compare the largest racial ethnic subgroups of the population, and then we can also compare men and women. These are age adjusted so that you can fairly compare. It's as if they had the same age structure, because age is a big contributor to mortality. So it's the overall crude rates that are the ones that really represent the disease burden in the population and that should drive policy and programs. These graphs are really more specifically focused on helping to parse out some of the differences, but with a fair comparison, again, adjusted for age between these subgroups. And so so I said this last time, but I'll say it again. One thing you might notice off the bat is that across the board, the orange line, which is the line representing white people experiencing homelessness, and the yellow line is much higher than the yellow line across the board, which is Black people experiencing homelessness. And this, sometimes is a head scratcher for people, because in the general population, mortality among Black people is higher than it is among white people. But the theory, and other people in other jurisdictions have found this interesting phenomenon, which is actually, it makes sense, because it's basically the things that are driving the overrepresentation of of uh, of Black individuals experiencing homelessness in the homeless population are the same reasons that you see this higher rate among white individuals, which is basically that there's a certain privilege that comes with whiteness in this society, and so people who are Black tend to become homeless because of socioeconomic uh, circumstances that may not be entirely related to health, whereas white people, the theory is that experience more accumulated years of sickness, hardship, trauma, and drug use before they become homeless. So that once they are homeless, that you're seeing people who are white be more frail, at the time they're homeless. But anyway, it's related to this. It's kind of a reverse relation to the fact that Black people are overrepresented in the population, because sadly it's easier for Black people to become homeless simply for because of socioeconomic circumstances or discrimination. That aside, what I want to focus on, and what we continue to focus on, is the direction of the curves, right? And so what your important thing is you're seeing here is that the white curve and the Black curve are both going down. So we're seeing over a 20% decrease. Actually, it's in this graph, which is about 26% among white, about 16% decrease among the Black group. And then the Latino group is kind of flat. So it's only 1 year of data, but that's sort of the take home here, is that we're seeing, in 2024, we saw overall decreases in both the white population and the Black population, kind of a status quo flat curve among the Latino population. For men and women, we're seeing decreases for both. So you see those curves going down by about the same rate. And then you'll see this graph repeated as well. This is where we compare the population of people experiencing homelessness to the general population. And so that pink line is the homeless population. The blue line is the population of the general population of Lake County. And what's most important in these graphs is the middle line, which is the ratio of the two. So it basically tells you that in 2024, people experiencing homelessness died at a rate 4.2 times greater than the general population. So slightly more than 4 times greater mortality rate among people experiencing homelessness versus the general population. That's what these are for, more for comparisons. You might see that curves look different in these adjusted graphs than in the crude graphs, but the crude graphs are the ones that truly represent the disease burden in the population. These are only created for comparison purposes. All right, and we have maps to share this time. So what we did, since this is the first time we've seen there were 300 fewer deaths, so we thought it would be important to look at that by our service planning areas. And what we see here is actually we didn't see uniformly decreases in deaths, in numbers of deaths in all the service planning areas. And in fact, in SPA 1 and in SPA 6, we saw an increase in the number of deaths among people experiencing homelessness. And so the overall decrease was driven mostly the dark blue where the decreases were the highest, SPA 5, 4, and 7. And the light blue spas is where it decreased also, but just not quite as much. So, and you'll see a pattern here, but we think it's important to look at this stuff geographically as well. And then I'm doing this this is sort of the order you'll see with the rest of the slides. These are the strategies that the working group came up with specifically related to all-cause mortality. So these are the strategies that are not disease specific. These are the things that we believe as a group will help us reduce mortality overall, broadly speaking. And so the first of that in that group, there's three groups there. First is about ensuring access to affordable housing and health insurance, really critical, that including sustaining and expanding interim and permanent housing options, sustaining and expanding opportunities to connect people to those housing options, very important, and then maintaining and expanding Medi-Cal enrollment. We have Medi-Cal eligibility now for people who are experiencing homelessness, but we need to continue to push and expand outreach and enrollment and to maintain that enrollment. The next two are about recognizing the contribution of mental health disorders to multiple causes of death. You don't typically see a mental health disorder on a death certificate, but mental health plays a huge role in from overdose related deaths, where there's often people with dual diagnoses. Mental health issues can contribute to disorientation and traffic incidents. So mental health is a big issue that's cross-cutting. And then the third is that we've also elevated is just generally recognizing and addressing the contribution of systemic racism and discrimination to multiple causes of death. And in here we talk a little bit in the report about sort of use as an example I guess the Blue Ribbon Commission, I think it was called the Commission on Black people experiencing homelessness, which has I think been going strong now for at least 7 or 8 years. So these are our recommendations for generally reducing mortality from all causes. Our second indicator, and this is where we're really seeing what's driving the overall decrease, is drug overdose mortality. And this is new. We now have a version of this initial graph for all the causes of death, which I think is helpful. So you can see here that we had 3 years of steep increase in the overdose mortality rate from 2019 to 2022. Then we had a brief flattening of that curve from 22 to 23, and a 21% decrease in 2024. So really, the biggest driving force of the decrease this year was drug overdose mortality. Typically, I don't have. I often bring ringers in, folks, doctors from our substance use prevention and control program who are experts in harm reduction and overdose prevention and drug treatment modalities. I can speak a little bit to that, but they're the ones with the expertise on that. But that's definitely the driving force here. And this again shows the on the left the racial ethnic differences, on the right the gender differences. And main point on the left is that, again, you're seeing decreases among white people experiencing homelessness. That orange line, you're also seeing, pretty good sharp decreases among Black people experiencing homelessness. And then the decrease in the Latino group is a little bit not quite as steep, but there is a decrease there. I believe that's 11% for Latinos, 29% among Black people experiencing homelessness, and 27% among white people. And then on the right, you see that we're seeing that decrease, even though the rates tend to be higher among men. We're seeing the same steepness in the decrease in 2024 among both men and women. And then this is the, interesting story here is that as you're seeing in 2024, that steep decrease in the mortality rate among people experiencing homelessness, the pink line, um, the rate's a lot lower in the general population, that blue line, but proportionally, actually, the rate decreased by closer to 30% in the general population. So even though we had great pretty sharp decrease in the homeless population. It wasn't quite as steep as it was in the general population, so that ratio yellow line actually tips up a little bit. So that's why you're seeing that go up, despite the fact that the rate has increased significantly among people experiencing homelessness. We have lots of data on drug types. I'm not going to go through them all for an interest of time, but what you're seeing here is that this tells you which drug types were involved in each overdose death. And most overdose deaths involve multiple drug types, right? So in any given year, you're going to see those percentages add up to more than 100% because about 2/3 of overdose deaths involve multiple drug types. But what's important here is that this purple line, which is the fentanyl line, it decreased for the first time in 2024. So you're seeing a drop off from 70% to 59% in the percent of overdose deaths that involve fentanyl. So that's definitely part of what's happening here is due to a decrease in fentanyl related overdoses. Um, and here is the data mapped. And here you see that the number of drug overdose deaths increased in SPA 1 despite decreasing in every other SPA except for SPA 3, where it basically stayed exactly the same. So again, seeing some differences by geography. And then the 6 recommendations we have around reducing drug overdose mortality. I'm not showing you the tables with all the partners and their roles because it's too much. But if you want, I think the link to the report is available at the end. But so our 6 recommendations for drug overdose mortality prevention are: 1, ensuring that housing options for people experiencing homelessness support harm reduction, overdose prevention, and substance use treatment goals. 2, sustaining and expanding comprehensive efforts of our department to reach the vast majority of people experiencing homelessness with substance use disorders who don't seek care. That's why it's called the 95% initiative. It's an initiative of our substance abuse and control program, and it's referencing the fact that 95% of people with substance use disorders don't seek treatment. So it's just and in order to reach them, they're really pulling out all the stops to lower barriers to care, and lower barriers to treatment, and seeking out people where they are, because that's really what this work is about. Third one is about expanding and extending harm reduction and overdose prevention services to where people are located. So whether it be emergency rooms, jails, um, encampments, and congregate living facilities, anywhere, bringing the services where people are. Second to last one here is about integrating peer-driven and peer-led services, because we know that that's a very evidence-based modality, is to include people with the experience of managing to kick that habit. And then finally, there's a piece here about policies and regulations, constantly working on making sure that we're advocating for policies and regulations and laws that make the continuum of substance abuse prevention, harm reduction, and treatment services more accessible to people experiencing homelessness. All right, so our third key indicator is about heart disease. Heart disease also went down. Heart disease is not quite it's a little bit more volatile over time. This one's hard not to crack, because I hear from a lot of our medical experts how it is most people, it's the biggest cause of death in the general population. Most people die because eventually their heart gives out. And so figuring out what the particular precursors are can be challenging, especially when we don't have a lot of information particularly in the case of people experiencing homelessness. But I'm going to get to that a bit in the recommendations. But we did see after an uptick in 2023, the rate is back down to kind of like the average over the past 5 or 6 or 7 years. So a decrease, and that definitely contributed to the overall decrease. But we'd love to see that continue to go down. And we're working particularly with the medical director of our new Housing and Homeless Services Department on this work. Um, Here you see that sort of heart disease went down the most in 2024 in the white population on the left, the orange line. Also went down in the black population, but the green line is the Latino population. It actually went up. So there was an increase and there has been for 2 years in heart disease mortality in the Latino population of people experiencing homelessness. And then we see slightly steeper decrease among males in the heart disease death rate, and then decrease, but a little bit less steep among females. And then we had a big jump. We were kind of heading down in the right direction towards about 4 times greater mortality among people experiencing homelessness from heart disease in 2022. That jumped up in 2023. And despite the decrease in 2024, the ratio of the two is kind of steady because the rate was going down in the general population about as much as it was in the homeless population. So that didn't really affect the ratio of the two. And you're seeing a pattern here. SPA one again, we're seeing more heart disease deaths this year in 2024 compared to 23 in SPA one, also in SPA two, and a slight increase as well in SPA six. So we saw the most decreases in heart disease mortality in this population in SPAs 3, 4, and 7, and then also in SPAs 5 and 8. And then our recommendations for reducing heart disease mortality include sustaining, expanding comprehensive primary and preventive care services for people experiencing homelessness, expediting and facilitating unhoused patients access to cardiac testing, medications, procedures, and care. This third one that we're doing a little bit more focus on in terms of the data is addressing substance use disorder as a contribution to cardiovascular deaths, particularly stimulants like methamphetamine, if used over a long period of time, can cause deterioration to the cardiovascular system. And so we do see, and we were up this year to about 1 in 4 of the drug deaths was the only mention was methamphetamine. And there seems to be somewhat of a sense in the community that, oh no, you can't have an overdose from meth. But I mean, you can't have necessarily an acute overdose from meth like you would from an opiate setting here. But particularly among older people who've been using these stimulants for many years, it causes over time it causes deterioration of the cardiovascular system, and so these stimulants, meth, have a big contribution to heart disease deaths. And so we're doing a focused analysis here, trying to isolate that and to kind of figure out how we can work on that particular lever. And then also training health and social service providers to better understand and accommodate the special needs and circumstances of this population when making their disease management recommendations, because oftentimes these people won't have a place to be able to refrigerate medicines or to even keep track of prescriptions or to get to appointments. So it's really about understanding that chronic care management, which is a huge industry in healthcare, looks totally different when you're dealing with a stressed population like this. So I just have two more to go through. Oh no, wait, sorry, three. But okay, let me do traffic mortality and then maybe pause because I've been talking a lot. But I want to talk about this one. This is the one. This is the graph that is looking terrible. In other words, besides a small downturn in 2019 and a sort of plateau for the between 21 and 23, we've seen this rate really go up and up and up, and it's even beginning to approach the rate of heart disease. And it's so I've already started to look at this data. This is, I think 95% of these deaths are among pedestrians and, including bike riders, but mostly pedestrians, but pedestrians and bikes. So very few are people in cars. And hot off the press, like something like, what was it? Yeah, 40% of them in a recent analysis I did, 40% of those are hit and runs. And they keep good track of that in the medical examiner data. And so, and all of our transportation departments, our public work departments that deal with, Vision Zero and how to make our streets more safe, they rely on this state data from it's a traffic injury data system, it used to be called SWITRs, to create these high volume corridors where a lot of accidents and deaths occur. But a lot of that, it turns out that a quarter of those deaths are among people experiencing homelessness. So you can't possibly reduce traffic injury deaths if you don't focus on this population, because they literally make up 25% of them. There's about probably people experiencing homelessness make up 1% of the population, but 25% of the traffic deaths. So it's yeah, and reading through the descriptions of these it's horrifying. It's yeah, so it's something that we're really focused on this year. 232 just in 2024 alone. And yeah, this on the left you see this really dramatic spike in traffic deaths among Latinos experiencing homelessness. Um, we've did triple check that. 1 year doesn't necessarily make a trend. I'm hoping that is just a 1 year phenomenon. But yes, that is correct that we actually saw decreases in traffic deaths among both white and Black people experiencing homelessness, but a jump among Latinos. And then males and females, very similar, increases among both men and women. And not a surprise since we saw an increase overall in the homeless population and kind of a steady flat curve in the general population. We've seen a dramatic increase in the ratio. So now most people experiencing homelessness, uh, mortality from traffic is 24 times greater than the general population. And traffic deaths going up in every single spa, except they went down a little bit in spa 4 and stayed the same in spa 3. And as I alluded to, we're doing a more detailed analysis of the 24 traffic deaths to try to inform preventive and policy and program uh, and infrastructure interventions. We've already piqued the interest of folks who we don't engage as much with, people in the transportation sector. But I think these numbers are alarming enough to really draw them in, and so we're spending extra time on that. So I have basically I have similar slides for homicide and suicide, and then I would wrap it up. I mean, would you like me to finish those off or stop talking a bit, or what would you like me to do?
Yeah, let's keep pushing on what you
Okay, okay,
on that suicide and homicide,
okay.
Dr. Nicholas.
Okay. So good news on homicide. I think this is, we've seen this in police reports across the city and county in general, that after a peak during the peak of the COVID crisis, we're actually seeing homicide rates go down considerably. So they went down very sharply in 2023, and they continue to go down in 2024. So things are looking good for homicide front. Not quite as low as they were, in 2019 before the pandemic, but definitely heading in the right direction. Um, and what you're seeing here is, yeah, interesting curve. So that green line is the Latino line, which has been higher, the highest group, but heading very steadily down. And so what you're seeing now is that they're kind of converging. So the homicide rates are very similar among these three racial ethnic groups, whereas they had been fairly disparate early on. And then, you know, despite slight increases, actually, well, yeah, I think I think I have the data here. So we saw a 50%. Oh no, sorry. For yeah, so we have, I don't have the percentage, but a pretty steep decrease in homicide rates among Latino people experiencing homelessness, an increase actually after a steep decrease in 2023, creeping up a little bit among the white and the Black populations. But again, all now sort of converging a bit. And then interesting, this is an interesting one on the left. So on the right, um, all of the decrease in homicide this year is really, all due to cutting like more than half as many. I'm sorry, the rate is more than half as much as it was among females in 2024 compared to 2023. As you can see, the homicide rate among males experiencing homelessness stayed pretty steady, but we saw a pretty dramatic decrease among women, which is wonderful. So yeah, so that's also good news. Um, and then not only is the rate going down overall among people experiencing homelessness, that pink line, but the ratio with the general population is also gradually going down. It's at 14. That's still, a big gap, but it's the lowest that it's been since we've started recording that. Yeah, we didn't have good age adjustment data to do these comparisons before 2020, which is why these graphs start in 2020. But anyways, the ratio is the lowest that it's been for homicide since we started tracking this. And then yeah, since we're now doing this focus on our recommendations on specific causes of death, we this is the first year we've really reached out to our Office of Violence Prevention which is now part of our Department of Public Health. They have a trauma prevention initiative that's been expanding. I think it's in 9 or 10 communities countywide, and people experiencing homelessness are part of their population served. And so we've been in talks with them, and we developed this recommendation about ensuring that the trauma prevention services, such as street outreach, community violence intervention, and hospital-based violence interventions, are available to individuals who are experiencing homelessness. They're supposed to be, but now there's going to be more attention on this, including ensuring that adequate resources and referrals are in place to help people victimized by uh, violence obtain housing. And then this is the last one is suicide, which again, these are the numbers are smaller, but sadly, after inching downward for the past several years, we saw a spike in suicide deaths in 2024. So again, it's not all 100% rosy picture, but yeah, so we saw that, and as you can see from the numbers, it's technically the highest suicide rate that we've seen in the population since we started tracking this. It's very similar to what it was in 2018. Again, we're hoping it's just it's 1 year, so we hope that this, 1 year doesn't make a trend, but it's worrisome. So, and what you see here on the left is that it's a little steeper in the white population, but it's going up in all three. And on the right, it's yeah going up more among males than females, going down a bit among females. I don't have the age group graph here, but suicide has been consistently higher unfortunately, among the youngest, the 18 to 24 year olds, which is so sad. And that continues to be the case, although we did see, not sure why, but we did see a bit of a spike among the oldest age group this year as well. But but consistently over time, it's been the youngest folks who've had the highest suicide rates. And then, yeah, so with the increasing rate overall in the homeless population, and actually a decrease in suicide in the general population, we saw after 4 years of steady ratio of the two populations, we saw that jump up from 8 to close to 13 times greater suicide mortality among people experiencing homelessness compared to the general population. And then this is, yeah, that's my last slide. So as far as strategies to reduce suicide mortality, we've connected with our colleagues in the Department of Mental Health, and they helped us with these recommendations. The first one being to provide, this is sort of more direct. The first one's more about direct services, and the second one's more about empowering and training others who are interacting with people experiencing homelessness. But the first one is about providing outreach, engagement, risk assessment, treatment, and post-vention response services. This is part of the lexicon of suicide prevention, working in collaboration with housing and homeless service agencies, including yeah, suicide risk screenings, treatment for people with suicide ideation and behaviors, and then suicide post-vention response for death by suicide in the community. And the second one is about providing suicide prevention trainings for clinical and non-clinical staff who are working in interim and permanent housing settings, and with a particular focus on youth. So providing clinical, there's a something called, yeah, QPR, provide question, persuade, and refer. It's a training modality that helps frontline folks who are not necessarily mental health providers to understand the signs and symptoms of suicidal ideation and to act as a gatekeeper and get people, help if they need help. So that is yeah, so I got our website there. I can send you the link to the report afterwards. But yeah, that is the how long is that? All right, well, not too bad. I think it was about half an hour. So yeah, so I'd love to open it up for questions, discussion. That's why we're here. So appreciate the time.
Dr. Nicholas, thank you so much. It was a wonderful presentation on, even though the topic is so difficult, mortality, morbidity, whether it is our unhoused Angelinos, our housed Angelinos, it's very difficult. So thank you for all the work and efforts that went into this report, and just for how you so concretely and concisely distilled it for us. Um, I think I have a question before we open it up for questions, if I may. I noticed that for so many of the indicators, SPA won. Although other spas had decreases, SPA one had increases. Could you talk to us a little bit about that, please? And I think SPA one's
Yeah.
Antelope Valley, Palmdale, that area, right?
Yeah, it is. And I will borrow from it. I learn a lot from my colleagues on this, but that question was asked at another meeting, and our uh, physicians in the substance use program made the comment that the geography is much more spread out in the Antelope Valley, and there is a sort of safety in numbers kind of a phenomenon that
Hmm.
sometimes happens in terms of having a friend or support person nearby who could help prevent an overdose death, for example. So that's one thing that I've heard mentioned in relation to what might be different about the Antelope Valley. I have my own theories too, which is that Antelope Valley, it's a little bit separate, right, from the rest of our county. It's further away, and um, it's possible that things, because it's further away, all kinds of things might happen there. It might take longer for things to happen there than they happen in the rest of the county. It's not shouldn't be that way, but that's another possibility. We saw that nationally, a lot of the fentanyl deaths, they really began several years earlier on the East Coast, and it took even it was 3 or 4 years later before we saw the crisis hit LA. So I don't know if that's part of the phenomenon that there's a lag because the Antelope Valley is more separate geographically from the rest of the county. That's a theory. Um, yeah, I'd love to hear what other folks think. So yeah, so I guess the so we so what did I say? Yeah, so the drug overdoses were yeah, traffic injuries, so heart disease, um yeah, and the numbers, I mean the numbers are a little smaller because the population there is a little smaller. Yeah, it is again, remember this is the first year we're reporting this. This is the first year we've had any decreases in deaths, and so it's new data for us. And so I will admit that we kind of have the same question that you have as looking at it, like, wow, what's going on here? We got to do something about this. So, um, yeah, so I guess I could even say that we're in a bit of a fact-finding stage on this.
Okay. Thank
Yeah.
you so much. I know we also have a few questions in the chat. I think it would be great if we opened it up to our members here. If you have a question, please raise your hand so we can call on you. And we ask everybody to limit their question to a concise question of up to 30 seconds, and I set a timer. So, any questions for Dr. Nicholas?
Ah, forgot to put well, I'll just leave that.
Yes, Dusky.
Um, Hi, Dr. Nicholas. My name is Dusky Wanamaker. And I am Northridge Indivisible Treasurer, but I'm also an organizer for Raising Cane's Movement, which is a group of seniors and others trying to protect Social Security, Medicare, Medicaid, Affordable Care Act. And through the work that we were doing last year, we came across a woman, a homeless woman named Elaine. I hope she's not dead. I don't know how to find her now. And let me just briefly take a couple of seconds to tell you why I need help. Through a lot of things, we managed to get her Social Security money that had been kept from her. We managed to help her in other ways to get a storage space. She chose to move out of housing she'd been in for quite a few years because she felt safer in the streets. And this was last August, September, because the place she was living was filled with drug addicts and she was not safe there. So she chose to do that. I have lost contact with her. Several months ago, her phone stopped working. I can't reach her. So I would check on the storage space. My name is on it. Check if she paid the bill, I knew she'd be okay. I was gone for 3 weeks and got back yesterday, and they contacted me, said they haven't seen her. She hasn't paid her bill for the month of March. She's paid for February, and if she doesn't pay it by the 31st, she will lose everything, her storage space and everything's in it. Of course, the people that I helped her try to get,
Dusty, I'm so sorry to
I just
interrupt
need to
you,
know
but
how to
our
find her.
our timer went off, so I have 10 seconds. May I ask for your question related to this piece, please?
Yeah, I just need to know help. How do I find her? If I mean, I don't want her to be dead. I mean, I don't know who else to go to find her to see if she's okay.
Yeah, I would do, yeah. I mean, I as a researcher that, yeah, that's not my forte. I would, defer to maybe other folks on the call on that. Yeah, unfortunately, I don't have a good answer for that. I wish I
No
did.
agency. I mean, I don't know who to call.
Dusty.
Well,
Oh,
yeah,
Dr. Nichols, the new department that stood up needs to be contacted,
yeah,
um, and in the county. Um, it's their business to address these issues,
yeah,
not just simply research or policy, but in fact, resolution of crises and problems. So the new county department addressing homelessness, Dusky would be the
Okay.
place to go, and that number can be located for and with you. Circle back, and we'll make sure you get a name and the proper number. Okay.
Thank you. Thank
And
you.
if all else fails, you go back to public health and make them do it. All right, keep
yeah.
going.
Okay. Well,
Thank you, Supervisor.
yeah,
Thank you for your
thank you. I
question,
appreciate it.
Dusky.
Thank you.
Miss Russell?
Good evening, everybody.
Good evening.
To Dusky's point, though, there was a project called Better Angels, a piece of software that that foundation was working with. So, and it was designed to help track services amongst our homeless people, but I don't know who's adopted it because one of the things, hello, Mr. Nicholas, I enjoyed your presentation. It was very helpful because we're looking at ways to train our next community level outreach workers in light of all the cuts that have been made in homelessness, how we can be of assistance. And one, I noticed that for the heart disease, there was nothing about nutrition. And then the other one that stood out at me is the 18 to 24-year-olds committing suicide, and that screams Tay populations because our young people are becoming homeless. And then I didn't see anything about our numbers for seniors. And then where can we find the listing of the other nonprofits and social services or agencies so we can kind of see where we can best fit in to help augment and assist?
yeah.
And
Thank you
my
for that.
organization is Let's Make It Happen. I haven't put me in the chat yet.
All right. So as far as the numbers for seniors, and yeah, they're in the report. Yeah, sorry, I didn't share the slide in the presentation. But the slide that shows the suicide rates in the different age groups, including the oldest age group, is in there. There's also tables in there that tell you exactly in each year how many people in which age group, whether they're men or women, what's their race, ethnicity. So yeah, all that data is in the report, which I will send to Ria. to make sure you all have it. Um, in terms of, yeah, again, so nutrition. Um, yeah, these are, yeah, prevention. I mean, when I went, when I'm in public health, and so when we think about heart disease, we always think, physical activity and nutrition are important for heart health. Um, we don't, yeah, I think that's probably part of the individual provider patient education interaction when providers are interacting with people experiencing homelessness, their patients through street medicine, street outreach. Um, but and so when they talk about comprehensive preventive care services, that's kind of part of that. I mean, preventive care also involves recommendations for, yeah. Again, the term that's is maybe troubling, problematic here is a lot of lifestyle issues, like your what you eat and your physical activity, which is tough. I mean, people experiencing homelessness don't have as much sort of luxury to be able to, find nutritious foods potentially. But I know that that's generally part of preventive care, the preventive care that's recommended in the report. Um, and then as far as just general, same as the question before, yes, there are, um, our Department of Homeless Services and Housing has, outreach numbers to call if you have, questions or crises. And I should always have that on hand for those questions. I don't, but yeah, I would refer you to our new Department of Homeless Services and Housing for those kinds of referrals.
Well, Courtney, see
Make
if you can
that one
drop that.
recommendation for
Hold
us
on,
because
hold on for a second. Courtney, if you could try to drop that in the chat, that would be helpful. The new department and department head and the number, that would be useful. And Rhea, you're going to drop in the chat the link for the report.
Yep.
All right, and that would
Yes,
be
sir.
helpful as well.
Yep.
All right,
and I was just gonna
Joanna,
sim
go ahead.
I
You
was
got
just
other.
gonna simply say, just put it on pin in it on your list because of their ability to feed themselves and access nutritional food to
Mm-hmm.
impact their health on a positive way, period, is almost so far out of their abilities until it needs to be in targeted something. Yeah. In some kind of way, even if we're looking at the kind of providers that are handling the meals, if we have to try to find more, nutritional things, even at the missions, because another thing is their dental care. They
Joanne,
can't
we
eat
got other
salads.
people
So
trying
thank you.
to weigh in.
I said
Uh,
thank you.
Hey,
all right, we appreciate you. But I thought you were trying to ask a question that Dr. Nicholas raised earlier, namely, the identification of community-based entities that are collaborating with the Department of Health Services. Um, it seems to me that there are a number of such persons on the line on the Zoom meeting, Dr. Nicholas. So it may be useful to allow some of them to know how they could possibly um, access and or participate.
Yes, how they can reach some of those organizations, you mean? Or
No, the organizations reaching public health. Remember, you said
oh,
earlier that Dr. Davis and Dr. Ferrer made the recommendation that those collaborative entities be included in the report. And I'm suggesting that there may be others who want to collaborate. So you should
mhm.
then allow us to know how that can happen.
Okay. All
And
right.
if you'd like, you can share this information with us after the meeting, Dr. Nicholas, and we will share it out with the group in case it's not on hand at this time.
Okay. Will do. Thank you.
All right. Well, I think with
Number
that,
of people in the chat, Rare, were trying to get a word in, a question in. Are you tracking them?
yes. So I want to, before we close out, I want to go to the chat. So, um, all right, Dr. Nicholas, I'm gonna just go through the questions in the chat one by one in case you haven't had a chance to see them yet. Is there a chart that breaks down coronary heart disease death rates by age?
Um, um, there is definitely a table that breaks down the numbers of coronary heart disease deaths by age group.
Hmm.
Yes, so you can see um, the number of heart disease deaths for about six different age groups that we have in that table. Um, so yes, and then
Okay.
rates I can take. Yeah, yeah. Organ heart disease rates are always going to be. It's going to be a straight curve. Like with the younger people have lower rates, and the oldest have the higher rates. So that
Okay.
always is going to follow a straight curve by age. But you can see the exact numbers. I think it's table 3 in the report. Yeah.
Okay. And we put to all of our participants, we put the link to the report in the chat. So, do you have a page number for us by chance, Dr. Nicholas? Because I know that that's a long PDF, just so we can.
Those tables are towards the end, actually. There's a table
Okay.
of contents, and I think
Hmm.
towards the end of the table of contents is something that says, additional data, and those three tables are in that towards the end. It's before the lists of the partners and roles, but after the recommendations.
Okay. Great. Thank you. We have a few more questions, and one of them was, has diet been taken into account, nutrition awareness and food access? And this is,
Yeah, I'm
well, okay.
yeah, I mean, as a department, we have a whole program that deals with the food environment and food access and healthy foods. Um, the yeah the as far as for this particular population of people experiencing homelessness, there are food banks, there are
Mm-hmm.
food pantries, um, there are all the shelters, and a lot of the homeless serving agencies provide food. Uh, um, so that is definitely, yeah, that's part of the array of services that are provided in the community for people experiencing homelessness. Um, as far as and then as far as the impact of nutrition, that I mean, that's you want to get people healthy meals, and when you're
Sure.
homeless, you don't have the resources for that, and so that is part and parcel of what homeless service agencies do, in addition to trying to connect people with housing solutions, is giving them nutritious food. So yes.
Thank you. And then what are the statistics on older adult mortality? I think you alluded to this earlier, but I know it's a question in the chat, so I want to make sure that
Yeah.
we're directed towards those data, please.
Well, I think we mentioned in the report, but unfortunately, the average age at death is considerably lower among people experiencing homelessness, because
Hmm.
the wear and tear of experiencing life on the street. And so, whereas your average person in the county might die of heart disease in their 80s, 70s, or 80s, among people experiencing homelessness in the 50s and 60s. So definitely, we're seeing heart disease rates among much younger people in this population. Um, and yeah, and I guess I would also refer people to the tables that show for every single for each of these five causes of death, you can see precise numbers of people who have died from each of those causes by age group, in both 2023 and 2024. We have a table
Hmm.
that has the current year of data plus the previous years.
Okay. And I think in the question it's more statistics on older adult mortality overall between um, the county housed population and county unhoused population,
Yeah,
if I
we don't we
understand the
don't
question
break
correctly.
we don't break out our comparisons with the general population by age. We just look, globally across the populations.
Hmm.
Generally, mortality is higher among older folks. Yeah, I'm just trying to think of, yeah, um yeah, I guess I'm trying to figure out what might be helpful in terms of more specific data about older adults. we do have, yeah, there's actually also in the drug death section of the report, we actually do compare overdose rates by age group also. We have a graph
Okay.
that shows that. So you can see, for example, I wish I had it in front of me, that the there was actually a bit of a there's smaller numbers, but there are overdose deaths among older people experiencing homelessness. They tend to be highest among the younger groups, but yeah, anyway, that data is available in the section. I guess that would be indicator number two, which is the overdose mortality rate. And then
Mm-hmm.
there's several graphs in addition to the race, ethnicity, and gender. We have graphs by age for I guess we have those for all of the causes of death. So yeah, we do have mortality rates by age group. Yeah, I should have included. Yeah, that's a good note to me that like next time I come, I should include all the age related graphs in the report in the presentation.
Okay,
Yeah.
great. Thank you. And then the final question was, do you have any data or why the increases in SPA 6 similarly to when we spoke about the increases in SPA 1? And I
Yeah.
believe that is the last question in the chat.
Yeah, again, this is the first time we've seen this and this data by spot because it's the first time we've seen the decrease. And yeah, the fact that overall we're seeing increases in, I mean, I'm certainly aware of people in the county are aware that isn't, area of the county that's, you know, particularly if you look at all these reports that tell you about the Human Development Index or any kind of like global geographic health index, SPA 6 is an area of particular need. Um, so that probably has something to do with it. But yeah, again, I'll just say that this is we're just reporting this data now, and that you're kind of sparking my thinking on that is to look specifically at the different causes of death in that area to see what's going on there. Because you're right, it wasn't just SPA 1, although yeah, in terms of overall increases, it was SPA 1 and SPA 6. Um, for drug overdoses, we're doing pretty well. We had a good big decrease in SPA 6 for drug overdose deaths, but I guess
Hmm.
it was yeah, small increases in heart disease and then traffic deaths. So yeah, we have to look at it by cause too, because it's not universal. So looks like SPA 6, we saw increases overall, but mostly driven by um, traffic deaths and heart disease deaths.
Mm.
Yeah. So
Thank you. Thank you so much for answering all those questions.
yeah, no, they're good, tough but good questions. I appreciate them. Yeah, but it's this is what we're grappling with, and it's good to have data to work with to drive these processes. So yeah.
Supervisor, I'm going to pass it over to you if that's okay.
Thank you very much, Madam Chair. We appreciate you guiding us through this data intense conversation. This has probably been one of the more uh, data rich discussions, and I want to compliment those on the call who asked such important questions that caused Dr. Nicholas to return to the research lab and to the research bench to further tease out some of this data. This is uh, how might I say it colloquially, this is how the uh, EC homeless working groups get down, Dr. Nicholas. We,
Yeah.
we've dived into the deep end of the pool. We are intensely concerned about this, not only theoretically or academically, but through lived experiences and service as well as advocacy. And you've been kind to share your time with us tonight, and you've caused us to think more about the work that we are doing, and more of it to be done. So we extend to you, on behalf of the entirety of the Empowerment Congress family and those of the working group, our heartfelt thanks and appreciation for your time tonight.
Likewise, we'll look forward to coming back, hopefully with even better news next time, hopefully. Yeah.
All right.
All
Now,
right. Good
Rhea,
evening. I'm
thank you.
gonna take my leave.
Okay.
Oh, thank you so much, Dr. Nicholas. Yes,
Uh,
Supervisor?
I dropped you a note about the Portrait of LA County 2026 Measure of America, a social program of the social science. This is where there is a whole bunch of data on all
Mm-hmm.
of the supervisorial districts and the spas and the like. If you could drop that in the chat, uh,
Sure. And
people
you know that
will.
was featured in our last edition of Praxis too.
Yes, it was, and one of the big fans of it reminded me of it. So I wanted to make sure those on the call have a chance to take a look at it. It is data rich, uh,
Mm-hmm.
more data rich than the presentation, because it's a broader look at a number of the socioeconomic indexes or indices. And so for those who like data, uh, get some popcorn. You'll have a good time.
All right, let's drop it in the chat. I think that's our perhaps those are our marching orders then.
Yep.
So
Uh, if I were Pastor Johnson, I would say that was a benediction now unto him who was able. All right. Everybody good? All
all
minds
right.
clear?
It sounds like a plan, yes, sir. And
2 weeks
I
from
hear,
tonight, Rhea, what do we have?
pardon?
2 weeks from the night of the next
Yes,
meeting?
April 9th. And then word on the streets is we also have something going on June 20th.
Yes, June 20th.
So
The presenter for April 9th teed up at this point.
we have invited, well, may I keep it a surprise?
You can,
Okay,
yes.
thank you.
Ladies and gentlemen, it is a surprise. Stay tuned for that, and we will look forward to seeing you. Then I want to say, before the June 20th event that Rhea is just in love with, let me say to you, on April the 8th, April comes before
Yes.
June on my calendar, at the Center of Hope in Inglewood, uh, we will have a um, an appropriate 58th commemorative dialogue marking the anniversary of the assassination of Dr. Martin Luther King Jr. And we are focused on the issue of nonviolence um, in our community. And be mindful, it was Dr. King who said that poverty is one of the most clear and unjust forms of violence.
Mm-hmm.
I have said to you on a number of occasions that homelessness is the hard edge of poverty. And so, for those of you who are interested, go to the Days of Dialogue website, register. Breakfast will be served, dialogue will be had. It's going to be a powerful, powerful experience for us to reflect on the message of Dr. King and how it applies to the work that we're doing in our day and time. Thank you, Madam Chair.
Thank you so much, Supervisor, and thank you everyone for joining. We hope to see you on April 8th, and we hope to see you back here on April 9th. And then we hope to continue the party with you at our Juneteenth experience on June 20th. Thank you, everyone.
Okay, thanks.
Good
Bye.
night.
Good night.
Good night.